Thank you. Good afternoon. We switch now from the more structural aspects of looking at cells or cell connections to a hemodynamic issue, namely stroke. And when we are interested in understanding stroke, the pathophysiology of it, and the connection then to imaging, we first should understand a little bit about the mechanism that actually takes place after stroke is happening. And then, of course, if you want to evaluate a therapeutic strategy approach, again, you should be able to evaluate what can imaging do in that case. And the last issue, of course, would be the assessment of brain recovery during sort of evaluating a therapeutic success. But I'm not sure if I will come to this within the limited time here. So when we consider stroke, this is a problem due to a lack or a reduction of blood flow to a certain area. So if you have a clot obstructing the blood flow, everything downstream of this area that is supplied by oxygen and glucose will be affected. This is shown here. You see in the human brain, if you have an occluded artery here, then everything downstream to this would, in the end, starting with the core. I think this is, you have a core region that is severely affected, surrounded by a larger area where there's still some trickle flow, and which we call a penumbra region. And this will be of interest because even so it's called a stroke, a sudden happening, that doesn't mean that it's only this momentary event and then nothing happens. Instead, there's a complete evolution of a cascade of events taking place afterwards. When we look at stroke, at least clinically, we need to define this in particular terms. When you have an occlusion of a vessel, then you speak of an ischemic situation. And in the other case, if you have a rupture of a vessel and then sort of bleeding into the tissue, this would be called a hemorrhagic event, showing down here with the two different situations. And just to give you clinically how often one or the other appears is shown here in percentage, and you see clearly that the most relevant clinically is the ischemic stroke with approximately 90% of occurrence. Let's look first at the pathophysiology of what happens, and this can be done very well with animal models. When we look at the blood flow, and again, this is typical blood flow in human beings. We have in the normal tissue, brain tissue, we have approximately 50 milliliter per 100 gram per minute. And as you reduce this, you see that there are various different events taking place depending on how severely the reduction of blood flow happens. If this is only a slight reduction, you see that you get disturbance of protein synthesis, then selective genes are expressed. As you go down to approximately 30 milliliters, then you get anaerobic glycolysis happening. Tissue acidosis happens, and if you reach approximately 20 milliliters, this is when you have breakdown of energy metabolism. ATP is lost. And here on the right-hand side, you see what this is typically called. In the upper range, you have selective neuronal loss. Then you have glutamate release and all its toxic consequences to it. And then finally, as you reach approximately the 20 milliliter threshold, this is when you have an infarct happening. So this seems that we can describe it depending on how severe the blood flow is, but there's also another factor to be considered, and this is, for example, time. Severity of the flow alterations, I've just mentioned this. We start with protein synthesis, then as we decrease even further, we have the anaerobic glycolysis. Lactate is produced, tissue acidosis happens, and then even further energy metabolism breaks down. The duration of this blood flow disturbance, in the beginning you have, while you start with persistent restriction of blood flow, you get, as time goes on, you get tissue damage, and this becomes more severe. It spreads into what I showed you in the beginning, the penumbra region, and it eventually becomes irreversible. And then this means the cells die, tissue becomes necrotic. When we study this in animal models, particularly, we try to reflect the clinical situations, and you need to distinguish between the quality of reperfusion and what happens here. Depending on how well the reperfusion takes place, this will have an influence on the success of the tissue recovery. And also recirculation itself, depending on how well this is happening, may have an effect as secondary functional and metabolic disturbances. So the fact alone that you turn blood flow back on again does not mean that you have a tissue recovery. Putting all this together, this has been described already a while ago by Dirnagel in this nice diagram, that you have to face various different time windows at which particular events take place. In the beginning, you have the excitotoxicity. This is within minutes it takes place, followed by peri-infarct depolarizations that are also considered to contribute to the severity and to the further spreading of the lesion. And then on hours and days, you have inflammation as another factor to be considered. And then finally also later on apoptosis. This could be now complemented by even further events that take place. But this is just to demonstrate that by no means is this a momentary situation and nothing's happening afterwards, but this is once a stroke happens, there's a dynamic process of various negative events that take place over quite some time. So when we look at animal models of stroke, typically the most widely used animal model considers the occlusion of the middle cerebral artery because this best reflects the clinical situation. You can do this by electrocoagulation. You can do this by the so-called intraluminal suture occlusion technique, and I will show you this in a moment. And you can also do this by clot embolization, where you do a blood clot and inject this to mimic the clinical situation of occlusion. Then, of course, in the animal model, you have to consider or distinguish two situations where you look at permanent occlusion and where you look at transient occlusion, reopening the vessel in the model, and then observing maybe also the secondary problems. But here, in the permanent occlusion, you can look at the evolution of the focal cerebral ischemia, both in space and time. You can see it, how the severity would change in one location, but you can also see the spread, the expansion of the core, of the original core into the penumbra region, whereas in the transient occlusion, you can look at potential tissue recovery, but also at pathophysiological events that take place during reperfusion. MRI is, of course, not the only imaging modality to be used, but it's becoming, or has become more and more one of the dominant imaging modality because it allows to study a wide range of pathophysiological events or metabolic situations, and I will just point out a few of the more basic ones here in relation to the plasticity talk. We've heard other techniques also like the fiber tracking and others that are also of great value for stroke studies. We can look at vascular patency doing angiography. We can look at the tissue perfusion doing perfusion-weighted imaging. Of course, we can also do spectroscopy. If we do phosphorus spectroscopy, we can look at ATP, we can look at the energy metabolism and disturbances thereof. Diffusion-weighted imaging, and I will show you this in a moment, is a very valuable technique because it's probably the earliest imaging modality to show you the event or the event of stroke and the extent of affected tissue by this. T2 star weighted MRI indirectly can tell you something about the metabolic activity, about oxygenation of the tissue. And then finally, of course, relaxation techniques will tell you something about tissue water, vasogenic edema, various pathological events taking place. So coming to the animal model of the intraluminal thread occlusion, you see here from the base of a rat brain or a rodent brain, here the circle of Willis, and what you do is through the internal carotid artery, you insert a filament that you can advance if it has the right diameter all the way into the circle of Willis, and the middle cerebral artery, where it branches off, you just push it far enough to that point, and you can occlude sort of the supply of the territory that would normally be supplied by the middle cerebral artery. When you look at histological sections, and this is the TTC staining, which can be done very quickly after you have induced stroke on large tissue sections, you see the pale region indicating that you have a breakdown of metabolism in these regions. And then depending on the duration of occlusion, how long you leave the suture in place, you see that the situation... This is dying on me again. Can I have a new pointer? You see on the top version that the affected lesion is much smaller. Thank you very much. Than it is in the lower case where the duration has been extended. So let's now move to the application of imaging. In this case, here we look at diffusion-weighted imaging, or in this case, even quantitative diffusion parameter images. And you see here multi-slice experiment through a rat brain before occlusion. Now, in this case, the animal was not moved out of the magnet to occlude. This was a remote control version of the suture occlusion technique. And so you can measure on, and you see that directly after occlusion, you already see a diffusion change here in this area. And then as you follow this over 6 hours, you see the shift to blue is more and more pronounced, indicating that there is a more and more stronger change in the diffusion behavior. And also you can see that, for example, in this section, in the beginning, you don't really see much change, but then at the end, you see that this area is also affected. You can also learn something about the expansion of the process over time. However, at this point, you should realize you're only looking at a physical parameter. You look at water diffusion behavior. And apparently this has been disturbed by the occlusion process. You need to interpret this in the next step to understand how to interpret your changes that you observe. This is shown here. Now we have a diffusion-weighted image, but basically the same situation. Again, after 6 hours, you see here in hyper-intense the affected lesion on the diffusion-weighted image. Directly following this in vivo experiment, you do the histology. Again, you see the paleness or the tissue sections in a good correlation with the diffusion-weighted imaging. And then also in an invasive technique on frozen tissue sections, you get the distribution of tissue acidosis demarcated here in red, and at the same areas, a loss of ATP indicating you have breakdown of energy metabolism. So from this you would say, okay, what I observe here is apparently the area of breakdown of energy metabolism. This is true at this point after 6 hours, but as I indicated at the beginning, we have a dynamic process. Something is happening. So let's look at earlier time points. When we look at 30 minutes, this is an old image, so the image quality is poor, but you see the hyperintensity covers more or less the right hemisphere. The diffusion-weighted changes are spreading very quickly, whereas the tissue acidosis also covers a large area of the hemisphere. At 2 hours after occlusion, the situation is very similar. But when we look at the area of breakdown of energy metabolism represented by loss of ATP, we see that the situation is different. Now, different from the situation after 6 hours. Here, we don't have agreement between tissue acidosis and ATP loss, but what we observe at earlier time points is we have a core region where we already experience breakdown of energy metabolism, surrounded by a region that still has functional energy metabolism, but already shows anaerobic glycolysis being reflected by the tissue acidosis. As time goes on, you see that this core region sort of grows into the area of tissue acidosis, which then means after 6 hours, both have already become equivalent. The peripheral region has been lost to the expansion of the core. You can use this volume expansion information that you learn from imaging, from non-invasive imaging, to learn something about various drugs and treatment modalities. This is shown here in principle. You see this is the lesion volume measured from the diffusion-weighted images over time, and you see in the untreated animal, you see this rapid expansion of the affected lesion volume, and then you have a stagnation after a few hours. With MK801, which is an NMDA antagonist, you see that you only have a slowing down of the expansion of the process. With the other drug here, you see an instantaneous freeze after the drug was given. There's no further lesion expansion any longer. So you learn something about the mechanism, how these drugs work, different from invasive studies where you would look at individual time points and then just say, okay, this volume is smaller than this, so the drug has done some good effect, but you don't know how. In this case, you learn something, it stops expansion. In this case, it slows expansion. We can use a different model. As I mentioned earlier, we can produce blood clots, inject them through the carotid artery, and observe what happens. This is shown here. And but basically, it shows a similar situation. When we look at the ADC images, we see a large lesion, but then this expands a little bit, but most of it has happened, as we have already seen from the earlier curve, within the first 2 hours or so. We can look at the perfusion-weighted imaging situation. We see that we have a perfusion deficit covering more or less the whole hemisphere. We can also look at spectroscopic imaging and learn something about metabolic events taking place, and we see the production of lactate and the area of lactate expanding as time goes on. When we do a lysis treatment in such an animal, we observe something interesting. An hour and a half after the embolism, we start to lyse the blood clot, hoping for reperfusion, and we see that before lysing, we see a large affected area. We also see that we have perfusion deficit in this hemisphere, and we have production of lactate. Then we start lysis, and 2 hours after lysis begins, the ADC image already looks more or less normal compared to the pre-stroke situation. We see that perfusion has improved, even though it's only patchy. And then we see as time goes on that the lactate production is reduced, so lactate is washed out. Using imaging again, you can now evaluate your treatment and how long can you use such a lysis, for example, and by comparing different onsets of lysis after occlusion, you realize that, and again, taking the lesion volume as the gold standard to measure, you see that if you wait too long before you start lysis, then there is really no protective effect any longer. It's happening too late, and this time window is closely related to the clinical findings also. An interesting situation is combining this even with a further modality, as I mentioned in the beginning, including angiography. Let's start with angiography. This is a horizontal section, and we see the circle of Willis here in the two branches of the middle cerebral artery. We occlude, and this is in the first hour of embolization. We see that this branch, the right MCA branch, is lost, and then we start lysis, and this is in the beginning. There's no success of lysis, but after 3 hours, we see that yes, the middle cerebral artery reappears. So using angiography, we could be happy. However, when we look at the ADC down here, we see that apparently lysis has started too late. We learned that despite the fact that we have been able to reopen, recanalize the vessel, recovery of the tissue has not happened any longer. The next thing is something which I consider also quite important, particularly when you work with animal models, to consider morphological and structural changes. Yes, okay. What you see here is the situation of 1 hour occlusion in two types of mice, C57 black 6 mice and SV129 mice. And we see the lesion expansion at the end of 1 hour occlusion period. Then we reopened and we observed this over time, and just look at in the T2 maps the chronic situation after 24 hours. With the SV129 mice, we hardly see any lesion left at this time point, whereas when we look at the C57 black 6, we see a very pronounced severe lesion after 24 hours. So depending on what model you use, even so you use the same protocol, you may get different effects. What is this based on? We looked at the extension of the territory that is supplied by the middle cerebral artery, and we observed that in the C57 black 6 mice, this is a much larger territory, so it's a much larger region of the brain that is supplied by this vessel than in the SV129 mice. So occluding in these mice has a much smaller effect because a smaller directly affected volume in the periphery can still get sort of trickle flow from the adjacent tissue areas, whereas if this is a larger territory, original territory, such an effect is not possible. I think I will just quickly walk through here due to lack of time. You can, of course, also use fMRI, as we've heard in the earlier talk, for looking at functional deficits, functional recovery. This has been shown here in the rat, and with looking at four-pore stimulation, and you see on the healthy side, four-pore stimulation showing here in the somatosensory cortex works fine over 7 weeks, whereas in this animal on the affected side, right after stroke induction, we lose the activity. However, it spontaneously comes back in this animal after a few weeks. When we compare to a situation, a different animal within the same study, we see that the activation in the ischemic hemisphere is lost over the whole period. So you get, again, different response situations that you, on top of looking at the structural changes, at the morphological or metabolic changes, functional changes can be rather heterogeneous. Based on this, you can of course then also try to look at treatments, and again this is just to show you imaging modalities. You can label cells similar to what we heard in the earlier talk for the migration along the rostral-migratory stream. In this case, cells were first labeled and then implanted, and you see with MRI you can observe cell tracking from the implantation site to the ischemic lesion over time. You learn something that they may even differentiate in the target area. And you can also do similar things with bioluminescence imaging. Again, we've heard this before. In this case, it's a transgenic animal where cells that are expressed, neurogenesis cells express the bioluminescence signal, and you see this here in the healthy brain. You see that after stroke, you have a much more pronounced neurogenesis on the affected site, and that becomes develops over time even further. And then finally, you can bring these things together. You implant cells and you look for the functional recovery of these, and this is shown in this case. Again, here we have an animal where no treatment was done and where we made sure that these animals would not show spontaneous recovery. So here we have over 6 months, we have on the ischemic side no functional activation due to the stimulus, whereas in this case where we've treated the animal with stem cell implantation after 3 weeks, we have to be patient, but then after about 14 weeks or longer, slowly some activations coming back that is increasing further and further in intensity, and thus shows you that there must be some functional recovery to the treatment in that case also. So with this, I come to the end. Of course, there's a lot more that need to be considered in terms of pathophysiology and cascade of events for stroke. There's a lot more for imaging that can contribute and describe the individual cascades of events. But what I recommend, what is very important, and this is not only true for stroke, of course, if you understand the pathophysiology of your model very well, then you can choose the right tool to study what you're interested in. Thank you very much for your attention.